Hello, everyone. My name is Ann Cleveland, and I am a paralegal here at Lyles Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Medicare, Telehealth, and Telecommunications Technology in Home Health and Hospice. Today's presenters are Ashley Morgan and Gunnar Jurgensen. Attorney Ashley Morgan focuses her practice on regulatory healthcare compliance matters, fraud and abuse, and reimbursement issues. Ashley represents healthcare providers across the country in connection with a wide variety of health law issues, including administrative appeals of large alleged extrapolated overpayments, documentation concerns, compliance, medical board complaints, and enrollment or revocation issues. Ashley has worked with an assortment of providers, including home health companies, hospice agencies, primary care and specialty physicians, and physical therapists. Ms. Morgan is a certified professional coder and regularly assists providers in claim disputes with major payers, including Medicare and Medicaid. Attorney Gunnar Jurgensen graduated from William & Mary Law School in May of 2022 and went on to pass the Tennessee bar exam. Gunnar has further distinguished himself as a certified medical compliance officer and a certified professional coder. As an associate attorney with the firm, Mr. Jurgensen focuses on regulatory healthcare compliance matters, fraud and abuse, and reimbursement issues. He represents clients nationwide and practices out of the Washington, D.C. office. He has experience assessing client records for documentation compliance and private payer and CMS audit preparation, in addition to identifying and improving documentation deficiencies. Gunnar also helps providers navigate the administrative claims and exclusion/suspension appeals process. And now, without further ado, I present your speakers, Ashley Morgan and Gunnar Jurgensen.
Thanks, Ann. Thank you so much to everybody for being with us this afternoon. Good afternoon, Gunnar. How are you?
I'm doing good. How about yourself, Ashley?
I'm doing just fine, thank you. So today we're going to be talking about Medicare, telehealth, and telecommunications technology in home health and hospice. This has been a hot issue ever since the COVID-19 pandemic began. So we're going to take you through some background. You can go ahead and go to the next slide, Ian. We're going to take you through some background, and just initially a disclaimer for you all is that today's presentation is intended to be informational in nature. It does not constitute legal advice. We recommend that you reach out to your specific legal counsel for advice on specific questions, but we are presenting the information to you for your consideration today and just informationally. Next slide. Here's an outline of what we're going to discuss today. We're going to give you some background information about telehealth in general. Then we're going to start talking about some of the COVID-19 public health emergency waivers that are specific to home health and hospice. We're going to talk about Medicaid flexibilities, the Texas telehealth landscape, and then talk about policy changes that we might see in the future. All right, so telehealth. Let's go ahead and go to the next slide. Thanks, Ann. So what is telehealth and telemedicine? These are two terms we've heard a lot. So telemedicine specifically relates to actual remote clinical services. So your assessments, consultations, actual treatment that's being provided real time by a licensed physician or other healthcare practitioner. Telehealth is a more broad overarching term. It's more broad than telemedicine. It can include non-clinical services and can also include things such as provider training, administrative meetings, and matters, and also kind of overall kind of handles more so communications back and forth with your provider, you know, through email and other sorts of methods. So telemedicine and telehealth is a rapidly changing and developing field. We've seen a lot of changes, like I said previously, since the COVID-19 pandemic began. In particular, it's important to understand what's permitted in each state. Each state has their own specific rules in addition to the rules that have been outlined by CMS. And they vary very much for every state. And also, just depending geographically where you might be located in the state, there might be different rules and opportunities for patients. In addition, the COVID public health emergency allows specific flexibilities which may or may not persist after the public health emergency expires. We are going to be talking about that specifically later on in the presentation, but it's important to understand that the public health emergency will likely end soon. So it's important to know what we can continue to do and what we may not be able to continue to do so we can work on starting to transition away from practices that may no longer be permitted after the public health emergency ends. Okay, so we're going to take you through some definitions for some terms that we're going to be using in the presentation today. Interactive telecommunications, that specifically involves audio and video equipment that permits a two-way real-time interactive communication between the patient and a provider. We're going to talk about asynchronous store and forward technology. That's the transmission of a patient's medical information from an originating site to a practitioner at a distant site. This can include email, it can include portal messages, that type of technology. The originating site, that's going to be where the patient is located. The distant site is going to be where your practitioner is located. And again, states can and do have explicit definitions of what technology is permitted. So Health and Human Services has identified four modalities that they permit for, or four modalities for telehealth technology. These include live two-way interaction through video visits. They include phone applications, which we're referring to as mobile apps, remote patient monitoring, such as Holter monitors, and then store and forward technology like digital radiology interpretation. The Texas Medical Board has stated that it allows technology that allows a provider to communicate with and see and hear patients in real time. So that's important, see and hear, which means you need to have video. You can't rely on audio only. Texas Medicaid says that they permit two-way video, audio or data transmission, store and forward care, other than telephone or facsimile. So again, you cannot rely on telephone for Texas specifically. However, with that said, there are technology limitations and issues. There is a lack of broadband in rural areas, especially, there's places where 53% of the population do not have access to what they define as a benchmark service. I'm going to show you a map in just a second. But there's concerns about the access to internet, the speed of access, and the quality of that actual, access to, if you do have internet access, how well you can actually communicate through it. So in specific scenarios, rural areas are permitted to use audio-only services, but the physician does have to document and abide by the same standard of care that would be required if they were seeing the patient in person. And so they would need to document that there was an issue to internet access for the patient to provide a video visit, and then they would still need to be able to somehow provide the same standard of care as if they were going to do a video visit with the patient. And go ahead, Ann. So this map shows you an example of the issues with access to broadband internet in Texas. You can see the yellow areas. There is really 0% access to broadband, and there's a lot of yellow in this map. The darker blue shows where access is pretty good, but if you are having patients that are located in a yellow or even a green area, you could potentially rely on that audio-only exemption. It just needs to be documented appropriately in the medical record documentation. Okay, so I'm going to take you through a little bit of background about the reimbursement for telehealth services pre-COVID, pre-public health emergency. So prior to COVID, there were specific services where Medicare would permit telehealth services, but it really only applied to people who were in rural areas. And it had to be furnished via interactive video and audio. It had to be furnished by a physician or other authorized provider. The individuals had to be considered eligible. Specifically, they needed to be in a rural area, and they had to be receiving the service in a telehealth originating site. And remember, the patient is the originating site. So then, Ann, go ahead to the next slide. And these are the permitted originating sites pre-COVID. So if you were going to use telehealth pre-COVID, the patient had to be located in one of these specific areas during the telehealth visits. They had to be in a physician or practitioner office. They had to be in a critical access hospital, rural health clinic, hospital, etc. So you can see it was a very limited exception for telehealth services before the COVID-19 pandemic began. Obviously, that has morphed dramatically, but it is important to understand where we started out. Okay, and then in regard to HIPAA, specifically. The same requirements for HIPAA apply to telemedicine as they do to regular face-to-face interactions and services, which is important because, if we're utilizing telemedicine, you need to make sure you're protecting people's protected health information just as you would in person. And it is, I think, easier to have some sort of breach or issue when you're transmitting medical services via telehealth. The minimum requirements for a telemedicine system included full encryption of any and all data systems. There was no video storage of transmissions, and you had to have a secure peer-to-peer network and connection. Other potential HIPAA issues that you need to think about are the use of unsecured mobile devices. So if you have providers that are utilizing or providing telehealth services, you need to make sure that your HIPAA policies are addressing the use of personal phones and that they need to be secured. And if you're using unsecured systems such as email or text messages, that's a really important area to focus on to make sure you don't have a breach of PHI. In addition, another issue is that staff is not properly trained on how to use specific options for telehealth, so you need to make sure your staff is trained. Many times we don't see that a provider's notice of privacy practice addresses telehealth at all, so that needs to be updated in the notice of privacy practices. You need to have business associate agreements with your telemedicine providers, and always you need to have unique logins and passwords for your providers. You can't share logins, and passwords need to be updated on a regular basis. So previously, pre-COVID, Skype and FaceTime were not allowed because they were not secure and not HIPAA compliant. And Gunnar's going to be talking more about this as we get more into the presentation. There are exceptions, very much so, for these non-secure systems during the public health emergency, but previously they were not approved. And there was discretionary enforcement by OCR, which is the Office of Civil Rights, who oversees HIPAA, and waivers regarding technology for the COVID pandemic. And Gunnar, again, is going to be talking about that. But again, as I said on the last slide, you need to make sure your HIPAA policies address telehealth and telemedicine. It's very important that you are training your staff so that they understand what is appropriate, what's not appropriate, and what safeguards they need to be taking to protect information and to protect you from a breach. You need to make sure also that if you are utilizing telemedicine systems and you have your providers using tablets or phones or computers, that they regularly update their software and firewalls. I know a lot of times software updates will be pushed out that are critical because they're fixing a bug that has some sort of security breach. So you need to make sure that people are regularly updating their software. And you need to remember that the minimum necessary rule still applies even during the public health emergency. And the minimum necessary rule, just as a reminder, is that you only disclose the minimum amount of information that's necessary for someone to perform their job. So if you are talking to a biller, for example, you only need to provide your biller with the minimum amount of information that they need about a patient so that they can perform the job that they need to perform. And so there has been no waiver of that for the public health emergency. That is still in effect. And again, don't forget about breaches. You need to be aware of them. You need to make sure you have a system in place for receiving notice about possible breaches, a way to investigate those, and if in fact you do know that a breach has occurred, how to report them. All right, and now Gunnar is going to talk to us about the COVID-19 public health emergency waivers that are currently in place.
Awesome. Thank you, Ashley. And that was a great rundown of the whole telehealth and telemedicine circumstance that we find ourselves in, and a little background on that technology and things to look out for. So things definitely changed after 2020, especially in March 2020, when we went into the COVID-19 pandemic. During this time, with social distancing and other encouraged healthcare programs and treatment plans, face-to-face contact was not encouraged. So in order to expand access to healthcare and healthcare services, the ability to provide telemed services was greatly expanded, and a public health emergency was declared. So under this public health emergency, there were waivers created for HIPAA compliance, as well as for telemedicine services that previously were not permitted, but now would be permitted in order to, again, foster the access to care of those individuals who would not otherwise be able to be seen in person. So I guess, yeah, as the slide walks through, once the TAHC was declared, it triggered Section 1135 of the Social Security Act, which authorized the Office of Health and Human Services Secretary to temporarily waive and modify various requirements for Medicare, CHIP, HIPAA, et cetera. And Secretary Azar, who was the Trump administration's Health and Human Services Secretary, declared this initial THC in January 2020. And the declaration remained in effect into the Biden administration, who is set to end the public health emergency on May 11th, 2023. Now, May 11th, that's a very important date to keep in mind because that is when a lot of these flexibilities and freedoms that were granted during the public health emergency are going to start winding down. That also, as I'll discuss later on, is going to change a little bit, but it's just an important date to keep in mind for a variety of reasons. All right, so just getting into the waivers off the bat. So effective on March 6, 2020, telehealth services were permitted to occur across the country. I know Ashley had mentioned earlier that previously it was specific to rural areas and areas where broadband access might have not been available. Now it was expanded to the entire country. You were able to do these telehealth visits from the patient's home, while the patient was actually able to log in from their home as the originating site, whereas before there were restrictions placed on the home being the originating site, and patients would have to go to a secure site or some other facility to actually engage with a provider via visual communication or telehealth service. So there's the public health emergency, again, the waivers. For home health, we're going to sort of break it down, the home health waivers, or those waivers that affected home health, and those waivers that affected hospice care. So starting with the home health, face-to-face encounters, the waiver permitted the use of two-way audio and visual telecommunication technology for these face-to-face encounters necessary for certifications and recertifications. This was actually set to end at the end of 2022, but after Congress passed its reconciliation package at the end of 2022, this was extended until December 31st of 2024. So that's a pretty big extension, a pretty big impact. So just going forward, it's important to know that face-to-faces can occur using synchronous two-way audio-visual platforms. So that's just another important thing to keep in mind. And again, standard of care for those needs to be such that it'd be the same standards as if the patient was in person. So then there is also the ability for home health aides. Sorry, I'm a little mixed up with my slides here. Make sure I'm on the right page. So yeah, so telehealth services can be provided so long as it's within a 30-day period, so no more than 30 days. You can't do telehealth visits weekly or every day, depending on what the patient's plan of care is. It has to be within maybe once every 30 days is the preferred amount, and anything beyond that would require some exceptional circumstance or showing by the physician as to why that was necessary. So if, say, maybe the patient tested positive for COVID, so that planned encounter could no longer occur in person and telehealth was needed, would be an example where you could, I guess, get around that requirement of only occurring within 30 days or 60 days. The status of these telecommunication technologies, it became permanent actually after CMS issued its final rule, and also under the consolidated, the reconciliation package that Congress passed. This is now permanent. But again, those timeframes are also permanent. So it's important to make sure that you're operating within those either 30 or 60 days, depending on what services are being rendered.
And just a note too, so if you are going to utilize telehealth services as a home health provider, it does need to be indicated in the patient's plan of care that telehealth services are going to be used. They cannot replace in-person visits, so the in-person visits still need to occur, but you can provide services via telehealth. But again, you still need to provide your regular in-person visits, and you're not going to receive reimbursement for these telehealth services, at least right now. We're going to talk more about these visits specifically when we talk about the policies moving forward in the future. But again, you do need to make sure if you're going to utilize telecommunications technology and visits for your patients, it is outlined in that plan of care, and that you are using audio-video technology.
And okay, I was also going to touch on this too. It briefly touched on the previous slide, but this sort of spells it out even more clear. There is a difference between whether skilled care is provided in the home health context by a home health aide or non-skilled care. When skilled care is provided, CMS will permit one virtual supervisory visit by the RN overseeing that home health aide. And this, again, 60 days, again, there will only be allowed one supervisory visit within 60 days. And there's that requirement that unless exceptional circumstances exist to justify why there were two supervising visits. But that's not the case for non-skilled care. When there's non-skilled care provided, the registered nurse actually must be on site. So that seems a little counterintuitive, but when the care is not skilled, then the RN has to actually be there to observe and certify that the care is being provided in accordance with the plan of care. So moving on to the hospice landscape and the hospice requirements, similarly to home health, face-to-face encounters are permitted to occur so long as there is synchronous, i.e. two-way audio and visual communication between the patient and the provider. This was actually set to expire on May 11th, but based on the act of Congress at the end of December, this was extended until December 31st of 2024. So again, important for any hospice providers out there, if you are conducting a face-to-face encounter, you are able to do that using audio and visual telehealth services, again, so long as you're able to meet that standard of care and review the records needed to fully certify that terminality. And on regards to, again, similar to home health, when you're providing services as part of the patient's plan of care using virtual platforms, you are not able to bill for these or be reimbursed for these. The same goes for the face-to-face encounter. Face-to-face encounters generally aren't reimbursable anyway, but even more so, the virtual face-to-face encounters are not. Only in-person visits are to be recorded on the hospice claim. So if there is a phone call or some other virtual or telehealth visit that occurs, make sure you're not billing for that and it's not on the claim form. You can provide those records depending on the circumstance, but do not bill for those services. So another very important aspect of telehealth, as Ashley touched upon earlier, is the HIPAA waivers and what HIPAA requirements are needed, given that obviously this is using the internet and potentially unsecure interfaces. So in the beginning of the public health emergency in 2020, Congress and the President President through Health and Human Services authorized non-HIPAA compliant platforms such as FaceTime, Skype, Google Duo, WhatsApp, Facebook Messenger, any of those platforms to act as a platform for telehealth services. And none of these platforms are HIPAA compliant. So if you were to use these, you would run afoul of the OCR's requirements and possibly have some OCR actions taken against you. But based on the waiver, that is no longer the case. However, this is all set to change. Next slide. On May 11th, 2023, providers who provide telehealth services will be expected to use a HIPAA compliant platform. Some of these HIPAA compliant platforms are Zoom, Healthy, WebEx for healthcare, GoToMeeting. Specifically with Zoom, they do offer a HIPAA and high-tech compliant plan, which is very important. And I know a lot of EMR systems and other electronic records systems have contracts already with some of these providers and platforms. But again, it's just important that you're using one of these because they are certified as HIPAA compliant because they are secure and protect patient personal health information.
Yeah, and it's just important to make sure if you are utilizing Zoom or GoToMeeting, that you are using, as Gunnar said, the HIPAA compliant, which typically is a higher fee that you have to pay. It's definitely not the free version of the software. And these companies will typically sign a business associate agreement for you.
And if they don't, that's a major red flag that they are not HIPAA compliant. Because if they are HIPAA compliant, they should be familiar with these business associate agreements and being happily listed as a business associate of yours. So Texas, and that whole conundrum of federal changes and waivers and that landscape, Texas has its own. So each state has its own telehealth and telemedicine requirements. And the states were generally ahead of the feds when it came to telehealth services. The federal government really only got involved after COVID-19, but before that, states were issuing their own regulations and requirements, Texas being one of them. So Texas has its administrative code, which specifically outlines the standard of care that's required for providers using telemedicine and telehealth services. Basically, it's the same standard of care as would be expected in person. So whether that kind of depends on the circumstance, there's some discretion there to the provider, but just ensure that it is up to snuff is really the main requirement there. And the Texas Occupational Code further outlines what constitutes a doctor-patient relationship within the telehealth context, which could include synchronous audio-visual interaction, which is audio-visual two-way, as we discussed before. It could be a phone call and other forwarding technologies. So say you're emailing a potential patient and you're providing them medical advice that way, that can establish the relationship, or any other audio-visual telecommunication technology that allows the practitioner to engage with that standard of care. So again, yeah, really it comes down to the care being provided and the interaction with that patient. And it's important to note that Texas law requires each provider of telehealth services have a fraud abuse and prevention program in place prior to actually providing those services. Also, Texas requires that each patient is provided with the practices, policies, and procedures as it pertains to telehealth services, and as well as outlining exactly where the patient is to file a complaint with the board, the Medical Board of Texas. So you can't just allow a patient to come under your care without telling them where they can address any issues that arise during that care, because there is concern if you're not seeing the patient in person that they can be taken advantage of. So it's important that you're really spelling it out for them where they can file those complaints. Also, Texas requires that home health agencies that wish to provide those telemonitoring services, as we said before, those home health, I'm trying to think of the word, the
Holter monitors.
Yeah, the Holter monitors and technology similar to Holter monitors that you enroll with Texas Medicaid and healthcare partnership to essentially just be on their registry. And so they can keep tabs on exactly who is engaged in this program. And there is further information provided by the Texas Medicaid Provider Procedure Manual that really walks through more specifics for Texas telehealth providers. Now, it does provide for flexibility similar to those Medicare related waivers for the public health emergency, where nursing assessments could be provided synchronously using two-way audio-visual. However, when the COVID-19 public health emergency ends in the state of Texas, this will no longer be allowed so long as you're billing Medicaid. Again, it's important to keep in mind which patients are Medicare, which patients are Medicaid, as that will determine which requirements for telehealth you need to follow.
All right, now we're going to talk about the future and what's to come. Thank you, Gunnar. So, as we've indicated, the Consolidated Appropriations Act was passed recently, which made some changes to what's permitted and allows some of these public health emergency waivers to stay in place at least to the end of 2024. One in particular that is important for home health and hospice providers is the specific one regarding the originating site for telemedicine visits. So the waiver to allow beneficiaries to continue to receive telehealth services at any site, regardless of whether they are in a rural location, so they can continue to receive those telemedicine services at home. So your practitioners, your physicians that are doing your face-to-face visits, they may continue to do telemedicine visits telemedicine visits for your face-to-face encounter. Again, this is still just through the end of 2024, but that does give you that additional wiggle room to continue to have those face-to-face visits done that way. Also, in addition, hospice physicians and nurse practitioners can continue to complete certain requirements relating to patient certifications via telehealth because of the specific waiver. And so we did also talk about the telemedicine visits that can be provided by home health providers while patients are on care. So the CMS fiscal year 2023 home health prospective payment final rule was issued in November of 2022. And this specifically discusses the future collection of data regarding the use of telecommunications technology during home health episodes. CMS is actually establishing 3 specific G codes for home health providers to identify the services that are being furnished via telecommunications. So there's 3 separate G codes. We're going to go over what they are, but they are for 3 different things. One is for synchronous telemedicine services that are rendered via audio and video. Another one is for synchronous telemedicine rendered via telephone or other real-time interactive audio-only telecommunication systems. And then the third option is for the collection of data such as through remote patient monitoring. Right now, it is voluntary to report these codes. So as of January 1st, 2023, it's voluntary to report these codes when you're using telecommunications for home health patients. However, it's going to become mandatory in July of 2023. So July 1, 2023, if you are providing any sort of services to your home health patients via telemedicine, you need to make sure you're reporting these G codes. And really, this is for data collection for CMS. And I think this is, a good sign potentially, depending on how you feel about telemedicine services, just because I think this is CMS's way of seeing how telemedicine is being used by home health providers to see if it's something that maybe they might actually want to reimburse providers for in the future. So they want to understand how providers are utilizing these technologies and caring for patients, and hopefully they'll be able to, analyze the characteristics of the beneficiaries that are using these services being furnished remotely, and it'll give them an understanding of what's going on, so that potentially we could see some changes later on that might actually allow you to receive payment for these services that you're currently being told you can provide, but you're not going to receive reimbursement for. So these are the specific G codes that you can use. So the G0320, that is for the provision of services via audio and video. And the G0321, that is for services provided via audio only. And the G020 and the G0321, you're supposed to report both of those as a separate service, as a separate data line under the appropriate revenue code for each discipline providing the service. The G0322 is a little bit different because that one is for the collection of data such as data received through remote patient monitoring. And because remote patient monitoring spans a number of days, that's going to show as a single line item that shows the start date of the monitoring. And then you're going to actually put within the units field in your claim form the total number of days the monitoring was used for. So again, it's very important that you share this information with whoever is doing your billing if you're going to continue to use telemedicine for your home health patients, because as of July 1st, 2023, it's required that you report this. Even though you're not going to get paid for the visit, you have to report the G code. It's required. And again, if I didn't say it enough times previously, the G-codes are not considered home visits. So you're still going to need to supply or provide your visits that are being ordered in your plan of care. So if you're providing 3 skilled nursing visits a week, you still need to do those 3 skilled nursing visits a week in person, face-to-face. These telemedicine services are being provided in addition to your face-to-face visits, and they still need to be ordered in your plan of care. So it's very important that you just understand that. They're also not going to be, the G-codes are not going to be used to calculate your loop of payments. So it's just a completely separate service that you can provide in addition to the regular home health services that the patient is receiving. All right, and then Gunnar's going to talk with you a little bit about the Texas Medicaid telemedicine policy changes.
Yeah, so Texas has been, I guess legislators have been working a little overtime recently when it has come to telemedicine. A lot of things have been passed, a lot of things have been signed by Governor Abbott in the past year, year and a half. So starting with Texas House Bill 4, it made permanent the telehealth, public health emergency flexibilities that permit further telehealth services outside of just rural areas, whereas before, as we said, they were confined to those areas with limited internet access and access to care. Now it's expanding across the state and made permanent, so long as it's clinically effective and cost effective. And this allows providers in the state to provide better healthcare services to rural Texans and just Texans across the state, urban or rural, suburban, the whole geographic makeup. So that's nice to know. And I think it's also important to note that these services provided, especially those nursing assessments that we spoke of a few slides back, those need to be completed. Those assessments can't be conducted based on provider preference. It needs to be based on the patient's preference. So if your patient expresses that they'd like to see you in person for an assessment, that must be abided by. You can't prefer to do things via telehealth when the patient has stated before that they don't prefer that. So that's also important and sort of goes along with that firming up of telehealth services across the state of Texas. And then Texas House Bill 5 expanded broadband services to certain underserved areas that put a lot of state money into expanding internet access across the state of Texas. But it is important to remain vigilant because the Texas legislature does tend to change things pretty quickly and fairly unannounced. So it's important to keep an eye out for any remaining changes and whether certain services will be added to the list of those covered by Texas Medicaid or removed from the list. And importantly, on January 12th of 2023, HHS has stated that it is investing $8 million into Texas, Alaska, and West Virginia in order to expand their broadband access. So in Texas, not only is the state government using its funds to expand access, but the federal government is getting involved as well. So more and more patients you will see will likely have access to the internet and the ability to engage in telehealth services.
All right. Do we have any questions?
So Angela asked, I think actually you mentioned audio and video requirement for home health telehealth visits. And then she says it must be both, question mark?
Yeah, it does need to be both. Mm-hmm. Unless you're going to meet an exception for rural, but again, that exception is just for Texas Medicaid. So yes, for Medicare, you need audio.
Also on that note of audio and visual and the exception for rural areas and audio being permitted, that may change the areas that actually count as rural as broadband is expanded to more rural areas using these investments. So it might get to the point where audio is no longer allowed at all. So it's again important to remain vigilant of that. But yeah, as like a audio and visual.
Yeah.
Okay. Gotcha. Alrighty. And then we have Lisa asking if Texas will still allow home health face-to-face visits to initiate skilled services to be done by audio-visual means.
So yes, for now, for Medicare, because because the rule was changed through the end of 2024. So through the end of 2024, yes, you can still have your home health face-to-face visits through telemedicine. And that may change again, to be determined. Hopefully it will, but for right now, yes, through the end of 2024.
Okay, and then she kind of asked maybe a follow-up question, but DR or NP?
Yes, so whoever the treating practitioner is, if it's an NP that signs the plan of care, or if it's an NP that works in collaboration with the doctor that certifies the plan of care, either one is fine.
Gotcha. All right. Well, I think that's it for questions. You have another?
Good handout.
Okay. We have another question. I think this is about the G codes.
Oh,
is that correct? Yeah.
Yeah, that's what it looks like.
0320.
So yeah, so the question is regarding the G codes that are being reported for the telemedicine services for patients. So these codes are for Medicare specifically. They're not going to be reimbursed right now, but you have to report them. It's required to report them starting in July. So if you're providing a service to a patient via telemedicine after July 1st, you need to report the G code that's specific to the type of telecommunications that were utilized for the visit. So yes, you do need to put them down. They are not going to be reimbursed right now, so they're not technically billable. In regards to whether a Medicaid Advantage plan might pay, or a Medicaid Managed Care plan might pay, that's going to be specific to each care plan. So you will have to look and see if the payers are stating that they might be reimbursed for those codes. It's going to be a contractual decision.
Let me just double check to make sure we don't have any more questions. All right, well, that concludes today's webinar. Thank you all for joining us, and thank you to our presenters, Ashley and Gunnar. Everyone from today's webinar will receive copies of the presentation slides via email. If you have any questions about today's discussion or another healthcare law issue, please feel free to reach out to Lyles Parker. Thank you so much. Have a good one.
Thank you. Feel free to reach out to us via email if you have any questions.